Good afternoon, everybody. Good afternoon, everybody. This session is ready to begin. The session is spun. This session is ready to begin. Kenneth Yeates-Trotman from the Maryland Healthcare Commission will moderate this session. Kenneth? Oh, hang on one second. There we go. Okay, now we've got Kenneth back. All right, Kenneth, go ahead.
Yeah, thank you very much, Norm. Good afternoon. My name is Kenneth Yeates-Trotman from the Maryland Healthcare Commission, and I'll be your moderator today on this session of Improving and Expanding Analytics. And the underlying topic here would be improved data sources. We have three presenters today. The first presenter would be talking about assessing the utility and electronic health records and healthcare claims data to determine potential health impacts associated with opportunities for exposure and environmental contaminants. And that information will be presented by Susan Condon and Gonza Namlanda from the Environmental Public Health and Tracking Program from the CDC. The second topic would be on challenges and opportunity around mental health priority data. And that presentation will be done by Elizabeth Schroyer and Charlie Patton from Impact International. And last but not least, we have information presented on lessons learned from building a voluntary payer claims database in North Carolina. And this information will be presented by Daniel Kowalski from the Healthcare Cost Institute and Brad Hamill from Duke University. So we will start off with the folks from CDC. So Susan and Gonza, could you proceed?
Okay, I'm sharing the screen.
So Gonza, you're doing the slides and I'll start.
Okay.
Great, so thank you. First, I'd like to thank everybody for allowing us the opportunity to participate in this panel. Gonza and I have been talking about this project for some time. The goal really is to test the utility of both electronic health records and claims data to see if it can help us to get a better early signal of when environmental exposures might be occurring within a neighborhood, a community, a larger geographic area, and see if we can't use some of that information to help guide a better design of epidemiologic studies. Next slide, Gonza. Very important. The conclusions in this presentation are those of Gonza and myself and do not necessarily represent the official view of the Centers for Disease Control and Prevention. So just an outline of our talk. I'll begin with a brief introduction and background and then turn this presentation over to Gonza, who will talk about the methods that we've employed, touch on some very preliminary results, importantly talk about some of the lessons that we've learned, and then the next steps in this overall project. So why try to look at claims data or electronic health records as a tool to better understand the threats that may be posed by emerging environmental contaminants? So first, these types of data, while many people may think they're very busy and difficult to work with, and I will say we have learned a tremendous amount that Gonza will touch on later, but they really do provide a much more timely opportunity for us to look at data and what might be going on in a population. And just for comparison purposes, if we look at traditional population-based cancer registries, for example, those data will always inherently be a minimum of 2 years out of date. And that's because of the reporting system allowances that exist within statutory language that generally exists in a state that helped to create that registry. Secondly, that I think you would skip that, Gonza, so I'm still back on the other slide. that
sorry. Mhm.
that's okay, that's okay, that they are likely to be more geographically refined. As our speaker from New York just mentioned, there's an enormous effort to try to get sub-county data so that you can look more granularly within a neighborhood. And most importantly, it gives us the opportunity to look at other risk factors for comorbidities, as well as looking at pharmacy and laboratory test results. All of this can help us to better understand whether it looks like there might be, as I often say, noise in the system. Next slide. So why focus on the city of Newcastle, Delaware for our pilot effort? Well, there's several reasons. Most importantly, the city of Newcastle is home to a variety of industrial sources. In fact, it sits just 5 miles south of Wilmington, Delaware, and Wilmington has often been referred to as the chemical capital of the world. So lots of opportunities for environmental exposures. And in 2015, we noted that there were levels of some contaminants in drinking water that were found to be above the federal health advisory levels. So we thought this presented a good opportunity to take a look at this. And most important, our incredible partnership with our colleagues from the Delaware Health Information Network. They were excited about the opportunity to partner with environmental public health people and see if data that they work with a lot couldn't be used for another purpose. Next slide, Gonza. And then I think I turn it to you, Gonza.
Yes, okay. So thanks, Suzanne, for that introduction and background. So for our methods, as Suzanne has mentioned, our data source is healthcare claims data. And we have specific zip codes of interest that are within Newcastle City or just adjacent, the 3 of them that are listed there. So the population of interest was all healthcare plan members who resided in Newcastle County during the period of 2013 and 2018. So I think Dean or Delaware Health Information Network, the earliest year that they had complete data was 2013, and they were able to provide data from 2013 to 2018. We believe that this range of data will allow us to examine any differences in rates of health outcomes within the zip codes of interest as compared to other areas that did not have these high contaminants inside their drinking water. And then besides that, it will also allow us to look at any patterns in changes in rates before the intervention and after the intervention, which was in 2015, as already been mentioned. So we selected several health outcomes of interest, and we were guided by past studies that have either considered these same health outcomes. So we wanted to see if the results can be replicated in our study, or they have shown some sort of association in past studies. So we selected cardiovascular disease, hypertension, diabetes, high cholesterol, thyroid disease, and some cancers, for example, kidney and testicular cancer. So very early on, looks at the data, we calculated the percent of health care plan members with health outcomes of interest by year. So I'll just show the first table, which is the number and percent of all healthcare plan members with the healthcare outcomes of interest for the 6 years of interest. And we list about 10 health outcomes. I want to note that within some of these health outcomes, we've sort of grouped several together. For example, for hypertensive diseases, we've grouped together hypertensive heart disease, hypertensive chronic kidney disease, hypertensive heart and chronic kidney disease. For coronary artery disease, we group together the ischemic heart disease, angina pectoris, and acute AMI. And then also at the bottom of the table where we say any thyroid disease, we included anyone who had a diagnosis of hyperthyroidism, hypothyroidism, Hashimoto's disease, and goiter. So I want to note that we used ICD-9 and 10 to identify who would be listed in these health outcomes. So very early on, as you notice from this table, for the first 2 health outcomes, type 2 diabetes and hypertension, a high number and percent of healthcare plan members had these health outcomes. And then also towards the bottom of the table, quite a number of healthcare plan members had mixed and other hyperlipidemia and any thyroid disease. And then if you look at the table from left to right, we can maybe look at type 2 diabetes and hypertension. We note that the rate seems to be decreasing. Of course, this is a very crude look and very early look. We need to look at confounders and then also stratify the results and do more examination. So this is just a fast table trying to understand the data that we have. So for the second table, I just picked two of the top health outcomes. So that is type 2 diabetes and hypertension, and then stratified it by gender and age group. And we note for both of them, more female health care plan members were represented in these two. And then also age groups 45 and older were represented in these two diseases. So again, as I mentioned, these are just early look at the data as we're trying to understand the data. And then if you notice, we have some censored results. That is because of small numbers that are less than 10. And per our DUA, we were not able to show those numbers. So those are very early look at the data. And as next steps, we plan to evaluate the comparability of this data, healthcare claims data, in relation to population-based surveillance data for Delaware. So of course, this data represents all those people who have healthcare plans within Delaware. So we want to see, can we compare this information with population-based surveillance for the same health outcomes? And then, as I mentioned earlier, some of the aims of this study are to examine the differences in rates of health outcomes before and after remediation, but then also to compare the rates of health outcomes within the zip codes that have had higher exposure in drinking water versus those that had maybe lower or no exposure of these contaminants in drinking water. And then a third step that we're going to look at is to obtain clinical data of the same health outcomes of interest, and then compare our results of studies using the claims data and the clinical data. So there are some lessons we have learned along the way, working together with Delaware Health Information Network. We note that always think or factor into your project timelines the period that you need or the amount of time that you need to request the data, have that request approved, signing of data use agreements, and then acquisition process, which can take several takes or tries before you get a data set that you can use. So sometimes this can take much longer than the period that you would need to actually analyze the data. So we say that you need to factor that into your project timelines. And then also what we have learned is that there's a real need for collaboration between HIE members and public health. So the HIEs have an intimate knowledge of this data, and they're able to give us some information about the data quality. For example, were there any changes in documentation of healthcare claims over the years that would affect the data quality? Are there any changes in the organizations that participated or provided data that could help us understand some of the patterns within the data? But then also, the expertise from the public health side will also help put into perspective this data. For example, when we got our first cut of data, when we looked at the patterns of data, they were not really matching what we knew in public health. So as we all know, there was a change from ICD-9 to 10 that happened about 2015, and you would expect some sort of changes in the healthcare rates and numbers. But when we first looked at the data, we were not seeing that these patterns were consistent with what we knew. So working with Delaware Health Information Network, we were able to get a refresh of the data that would help us to get more complete data based on what we shared with them about the data. So I'll stop here and also hand over to Suzanne and see if she has any lessons learned that you'd like to add to or maybe comment on.
Thanks, Kanza. I really, I think you've covered it, but I will say that I can't stress enough the importance of this collaboration between certainly our partners at DIN, or if you tried this in any other state, how critically important it is to trying to understand the intricacies of the data. These are not traditional population-based
2 minutes.
registry systems that we've worked with before. And I think for us to be able to reach any strong conclusions, we would need to have the input and support of our DIN partners. And I'm just happy to say that this has been one of the best collaborations that I've had in all the years that I've worked in environmental public health, and certainly across agencies. So kudos to DIN, and we're really looking forward to working more with the data and seeing where it takes us. Gonza, the acknowledgements, obviously our partners.
Yes, I echo what Suzanne has said, and we would like to acknowledge, these are some members, of course there are more, and we couldn't put everyone here, from Dean, Terry-Lynn, Pierre, and Gurpreet, from Friedman Healthcare, Elizabeth and Tanya, and from MedicaSoft, Vlad and Carmen, and all their collaborators as well. Thank you very much.
Thank you.
Thank you very much, Gonza and Susan. So before we move on to the next segment, I have one question to ask you. So what are the challenges in linking EHR records in the high level or 7 or HL7 format with the administrative data in the X12 format? And what was the common identifier used for the linkage?
So I can say that Dean used an enterprise ID that they use to identify people across all their data sources. Whichever the data source is, everyone, they have a unique enterprise ID, and that's how they were able to identify them. About the underlying systems, that is something that I would put on Dean to better understand. We don't understand it on our end. What I will notice when we discuss this with them is that they are hoping by the use of the new standards of FHIR that those will not be issues anymore, because FHIR is supposed to be standard agnostic. So whatever you would use in an underlying system would not affect how you pull it out to use it for public health or other partners.
Thank you very much. So we will move on to the next topic. Thank you very much for your presentation. The next topic would be challenges and opportunities around mental health parity data. And this will be done by Elizabeth Scheuer and Charlie Patton from Impact International. Could you begin?
Yeah. Hi, everyone. Good afternoon. My name is Elizabeth Scheuer. For this presentation, my colleague and I, Charlie Patton, will be discussing some of the challenges and opportunities around mental health, including substance use disorder treatment parity data. But first, Charlie and I are both employees of Impact Health, which is a division under the company Impact International. Impact Health provides clear answers to the most important questions in healthcare, and we provide analytics, policy research, evaluation, and operational support to help state and federal agencies improve the country's access to affordable and high-quality healthcare. This includes supporting federal and state enforcement of mental health and substance use disorder treatment parity requirements. So today we'll summarize some of the challenges and opportunities to enhance mental health and substance use disorder parity through more robust data collection, compliance reviews, and public use file dissemination. First, I'll provide some background, and then Charlie will present some of our ideas. So when we talk about parity requirements, we're referring to the Mental Health Parity and Addiction Equity Act, or MAPIA for short, which was implemented around 2010. MAPIA regulates behavioral health insurance benefits by analogy. So that is, the statute requires that coverage for behavioral health be judged against the standard of coverage for medical and surgical services. So while MAPIA itself doesn't mandate mental health or substance use treatment coverage, when it does, it requires that benefits, financial requirements, and treatment limitations are no more restrictive than the predominant financial requirements and treatment limitations for medical and surgical benefits covered by the plan. So MAPIA covers large group plans, plans with more than 50 employees, and health insurance coverage in the individual health insurance market. And it should be noted that shortly after MAPIA was amended and passed, the Affordable Care Act, or ACA, was enacted. The ACA mandated coverage of substance use and mental health services for the individual market and small group plans, and defined these services as 2 of 10 essential health benefits. So there's 3 different categories of benefits limitations that we look at when we examine mental health and substance use disorder parity compliance. We compare these limitations on mental health and substance use services to the equivalent medical and surgical services. So like outpatient gets compared with outpatient, inpatient gets compared with inpatient, etc. But the 3 categories of limitations are financial requirements, such as copays, cost sharing, coinsurance, out-of-pocket maximums, and deductibles. Then we have quantitative treatment limits. So these are different levels of treatment limitations, including day limits on number of treatments, visits, or days of coverage. And then we have the non-quantitative treatment limits, which are probably the most challenging to evaluate. These are things like formulary design for prescription drugs. So we look at like medication-assisted treatment, methadone and buprenorphine for opioid addiction. Also network tier design, standards for provider admission to participate in a network, including reimbursement rates, exclusions based on failure to complete a course of treatment, restrictions based on geographic location, facility type, and provider specialty, and any other criteria that limit the scope or duration of benefits for services provided under the plan. So enforcement of MAPIA happens at the federal level through the Employee Benefits Security Administration and the Centers for Medicare and Medicaid Services, CMS. However, reviewing compliance before a plan is issued is a responsibility of the states. Each state may approach this enforcement differently. Typically, states review plans through the following activities: market conduct exams, processes where regulators examine the practices, policies, and behaviors of an insurer in the marketplace. So that might be after the plan is released. Targeted audits of plans and form filing reviews, that occurs before a plan is enacted. And that's where states review insurance plan documents that outline the scope of coverage, documents such as a schedule of benefits. So through our work with states on form filing reviews specifically and other compliance activities, we've identified the following challenges in enforcing mental health and substance use disorder parity compliance. So one of the challenges is inconsistencies in the format of insurance plan documents across plans. For example, one plan may talk about exclusions in a list format, while others may have the exclusions listed sort of in a text paragraphs throughout their forms. Lengthy manual reviews are required to assess particularly what I mentioned are the non-quantitative treatment limits, things like medical necessity language where a benefit might be excluded because it's not considered medically necessary. So yeah, things like that require manual review and comparing mental health and substance use services to the medical surgical services within a plan. Then it's just time consuming to work back and forth with insurance plans to see if the benefits language is justified. So one of the sort of rules is that if the plan can justify why they're implementing a certain exclusion, then it's allowed. So it's a little bit ambiguous, but it requires some back and forth and request for additional evidence. And then finally, there's just little research that can link this process to any impact on outcomes associated with access and utilization of mental health and substance use services. So yeah, we really don't know how much particularly these pre-reviews impact use of services. So next, Charlie will discuss opportunities for improving efficiency and consistency of parity enforcement activities.
Yeah, thanks, Liz. Yeah, so I'm going to spend some time describing data management strategies that states can use to help address these challenges enforcing mental health parity. So for each of these, I'll also describe what the Center for Medicare and Medicaid Services, Center for Consumer Information and Insurance Oversight, otherwise known as CIO, does as part of their oversight and certification of qualified health plans that are offered on the federally facilitated exchanges. Their role in enforcing ACA requirements for qualified health plans is very similar in scope to states' oversight of mental health parity. And so their data management approaches can serve as a model that states can adjust for their own purposes. So here we identify 3 interrelated strategies that states can take to improve their oversight of mental health parity. So first, states can standardize the structure of data collected from issuers as part of their form filing reviews. As Liz mentioned, many states review issuer policy documents to identify mental health parity concerns, but these documents are typically, PDF files that are structured and formatted differently across issuers. So to make reviews more efficient and to also establish downstream processes, states can use templates or other forms to structure the submitted health plan coverage information into consistent data elements. By structuring issuers' plan data submissions, states can then have the opportunity to provide automated review tools that could be used by both states and issuers. This could take the form of an Excel-based tool or an online tool that could receive issuer plan coverage information and flag any potential deficiencies or compliance concerns. This is something that could both be used by the issuer prior to submitting to the state to make sure they're compliant up front. And it also can be used internally by the state to automate their review processes, specifically focused on the quantitative and cost sharing requirements. And then finally, states can develop and disseminate public use files that provide information on plan coverage in their states. This can include information collected as part of mental health parity reviews, including benefits covered, the quantitative treatment limits associated with those benefits, and other benefit exclusions and utilization management language associated with those health plans. Public use files are very helpful for researchers and consumer advocates to investigate trends in plan coverage. And when it's possible to link to healthcare utilization data, whether it's an all-payer claims database or some other data source, it can be used potentially to identify impacts or relationships between health plan coverage characteristics and access and utilization of mental health services. So, as I mentioned, for each of these data management improvements, we'll be briefly discussing an example from CIO's data management strategies with a publicly available artifact for folks to visually reference. So here we have a snapshot of a template that CIO requires states to fill out when filing their state essential health benefit benchmark plans. This is a document that essentially describes what benefits issuers are required to cover in qualified health plans in that state. So this could provide a basic framework for how states can structure information that they're collecting from issuers. As you can see, this file requires the state to specify each benefit covered, whether it's classified as an EHB, the limitations, exclusions, things like that. And so states can, use this as the structure, but also customize it, to provide a little more detail. So states could require issuers to classify each benefit as mental health or substance use disorder versus medical or surgical benefits for the purposes of comparing for parity. In addition, they can break out some exclusions and explanation fields to capture more nuanced information on non-quantitative treatment limits, such as prior authorization requirements or medical necessity standards. Similarly, here we have an example of an Excel-based review tool that CIO uses, publicly available to issuers. This tool here it's a cost-sharing focused tool, so issuers upload their QHP, their health plan coverage data, which is stored in Excel templates, and includes information on co-pays and co-insurance, things like that. They upload it into this tool, they hit a button, and then they receive a list of deficiencies that would be flagged by CIO if they were to submit that plan as is. So this helps encourage issuers to clean up their data, clean up their plans in advance, rather than waiting for the back and forth that Liz mentioned between states and issuers, or in this case, between CIO and issuers. So if states are requiring issuers to submit standardized health plan data that includes benefit coverage and cost sharing information, they can develop similar tools similar to this one that would inform issuers of any parity compliance issues associated with cost sharing or quantitative treatment limits upfront. And once again, states then can also use that tool to standardize and automate their quantitative analyses when they're looking at mental health parity compliance. And then finally, we'd like to point to an example of disseminating health plan data. Once again, Socio here develops and disseminates a public use file or series of files that contain submitted qualified health plan data. This is composed of a series of Excel and machine readable files that contain health plan information such as benefits covered, coverage limits, cost sharing, rates, things like that. These files are helpful for researchers as well as consumer advocates to get a sense of the landscape in health plan coverage. And for the purposes of mental health parity, if states start collecting standardized, machine readable
2 minutes.
health plan coverage data, that allows them to once again produce similar publicly available data files. This can be particularly helpful, for states that have an all payers claims database, where you could potentially link, depending upon the structure and what information is captured in that database, you could potentially link healthcare coverage data with the claims data, acting as a source of, information on healthcare utilization. And you can investigate, individual, potentially coded quantitative limits or qualitatively coded prior authorization language to identify, what do those plan designs, how could they potentially impact individuals using mental health services. Getting back to Liz's point about, we go through this process of enforcing mental health parity, but it's helpful to know, particularly where there's maybe some gray areas on non-quantitative treatment limits, how that might impact mental health service utilization. And so that's just that's our presentation, just a high level kind of summary of strategies states can use to manage their health plan data when enforcing mental health parity. Here's our contact information. Definitely welcome folks to reach out if they have any questions after the conference. And also want to extend a very special thank you to our colleague, Elizabeth Messenger-Jones, who helped put together this presentation, but is out on maternity leave.
Thanks very much, Elizabeth and Charlie. Before we move on to the next segment, I just have one question for both of you. How could this approach be used in conjunction with the exploration of behavioral health claims to assess what patients face in accessing care?
Yeah, that's a great question. So, a lot of it depends on that utilization data source. Some states might not have, a very strong connection with the, a linkage data field to connect the plan in the claims data to the plan in the coverage file. But if they do, you can, once again, as I mentioned earlier, you can investigate different sort of plan design features, whether it's a non-quantitative treatment limit that you're interested in, or a potential, network tiering or cost sharing tiering, a plan design. And you can look at if there's sort of patterns, maybe not causal relationships, but correlations at least with, what services those members in those plans are actually receiving.
Yeah, and I would just add, I think that a mixed methods approach could be useful in terms of if a patient is wanting substance use services and they go in and there's all this prior authorization language and things like that, network adequacy issues, and maybe linking their experience to that data, the utilization data could be interesting.
Thank you very much. So we move on to the final presentation. And this presentation is No Legislation, No Problem, Lessons Learned from Building a Voluntary Multi-Payer Claims Database in North Carolina. And this presentation will be done by Daniel Kowalski from the Healthcare Cost Institute and Brad Hamill from Duke University. Take it right away, folks.
Great, thank you very much, Kenneth. Yeah, I'm Brad Hamill from Duke University, and Daniel's a co-presenter here today from the Healthcare Cost Institute. We're talking about a voluntary multi-payer claims database in North Carolina that we used for a specific kind of cost analysis that kind of hadn't been done before in our state. So we'll talk a little bit about that. I'm going to give a project overview and then turn things over to Daniel to talk more about the data strategy and the dissemination strategy. And then I'll kind of come back at the end and talk about some lessons learned and kind of benefits and limitations of the work that we did here. So this was about North Carolina. North Carolina is one of those states that does not have an all-payer claims database. So policymakers and other stakeholders just have never seen information about kind of overall population level healthcare costs and utilization, I would say, really in any comprehensive way. So that's what we set out to do. We wanted to create, I called it a pseudo APCD just because it wasn't a formally, legislated all-payer claims database. But our goal was to understand just key drivers of healthcare spending in our state and present that information to the public and to journalists and to policymakers so they could start to get a sense about kind of where healthcare dollars are going in North Carolina. So I've mentioned that Duke University was part of this work. The Healthcare Cost Institute was also one of our partners, and we're grateful that the Blue Cross Blue Shield of North Carolina agreed to kind of put their resources behind this project as well, and they were a great partner in this work. Oh, and I should say, back on the first slide, funding was provided by Arnold Ventures and the Commonwealth Fund. Couldn't have done this work without their generous support. So the main tasks that we had to do here are kind of shown on this slide. The one that took the most time, a lot of back and forth, a lot of email, a lot of meetings, was really harmonizing the methodology across all these three different groups. Daniel will describe a little more in detail kind of what this was about, but we had to come to consistent agreement on how we were going to identify the population to include. We had to agree on kind of what costs we were interested in, which segments of the insurance market sometimes. And then how were we going to put those costs into different meaningful categories that would be, again, consistent across all these different databases. So that took a lot of time, but once we had that done, each institution made kind of aggregate data summaries that were still detailed. They're not quite as aggregate as you might think here. We had spending by county and age and sex and detailed spending category, both overall and for a few specific groups of interest that were kind of some example potentially high cost populations. All these aggregate summaries were combined to make a final analysis data set. And then we hired a subcontractor to make, I think, a really beautiful interactive website as part of the dissemination strategy. And as part of that dissemination strategy, we also released a lot of the summary data that were behind the graphs and figures that were shown. And we also released the summary documentation about methodology so that others could potentially use this if they had interest in trying something like this in their state. So this was a project that we really just recently completed, and it had been going on for over a year. And again, each step along the way was important, and I don't know, I'm glad we finished. How about that? So just to be clear about what each group was actually contributing to this project, Duke houses the 100% Medicaid data in North Carolina. HCCI had the 100% Medicare fee-for-service data. And then both HCCI and Blue Cross Blue Shield didn't have complete, of course, because there are other kind of payers that weren't part of this work. But I would say a good chunk of the employer-sponsored insurance segment, and then again, a large segment of the Medicare Advantage population in the state. We had really two overarching kind of methodological or kind of logistics requirements. One was patient level data could not travel between institutions. That's why on the prior slide, when I said we did a lot of aggregate level work at our own institutions and then sent that away. That was the reason for that. We just couldn't, get all this data in one place. And in the end, I think, as we'll describe, that might have been helpful in some regards as much as it was, a challenge in others. And then HCCI was the group that put all this information together and worked really closely with the group that did the dissemination for us. So I will turn it over to Daniel now. He'll talk about the data methodology and other stuff.
Thanks, Brad. So a quick overview of the methodology. That includes our selection criteria for the enrollees for this data. As Brad alluded to, how we were going to categorize the data, both broad and detailed categories, how we constructed our spending and utilization measures, as well as some conditions of interest we looked at, and some episodes of interest. And then finally, I'll briefly touch on some adjustments we needed to make prior to dissemination of the data. I will go over this fairly quickly. As Brad alluded to, all of this methods stuff is available online. So if there's anything you guys want to look over afterwards, that's available. We identified members using their zip code and assigned them all to a county of what I'll say residence. Each contributor may call that something slightly different. An example is, for those of you familiar with the Medicare fee-for-service data, it's actually the address that CMS sends the correspondence to the beneficiary at. So it may not exactly be the residence. All members were required to have medical coverage, but prescription drug coverage was not a prerequisite for being included in the study. This is just something important to keep in mind when thinking about things like the Medicare fee-for-service population and those beneficiaries without Part D coverage. And then finally, each member was assigned to a primary payer group. We didn't consider any secondary payer information. I think there's an asterisk here that I will mention ahead of time, and that is, I'm sure some of you are asking, how did we handle our dually enrolled beneficiaries? And as Brad mentioned, we could not transfer data between institutions. And so all of their Medicare spending is included in the Medicare files, and all of the Medicaid spending is in those files. And we do a separate analysis to try to bring those two groups together. This is a broad overview of the four high-level categories we created: inpatient, outpatient, professional, and prescription drug. I won't go into all of this in detail, except to say that most claims have this information. So this was relatively straightforward task. The Medicare fee-for-service data, we relied heavily on the NCH claim type to determine what category everything would fall in. And then there was some musical chairs we had to do. A great example is the ambulance claims in the fee-for-service data come in on the carrier file, and it was just a matter of moving them when we conferred with our other data partners that we would count those claims in the outpatient category. Next slide. This is the detailed level categories we created for the inpatient, outpatient, and professional level claims. There's a lot of detail here, and I won't go into to great detail for this presentation, except to say that the behavioral health and case management was an interesting example of us going back and forth with Duke University. In particular, this category was created because it's unique to the Medicaid population, and it's not something that us at HCCI or BCBS of North Carolina really had to think about or deal with in the way we usually do analysis on our data. And so it took a lot of communication in trying to construct these categories so that they made sense to each of the institutions that was contributing data. Next slide. As I said, we constructed spending categories. We calculated the allowed amounts as well as the out-of-pocket amounts. We didn't do any calculations for premiums. We didn't take plan design into consideration. So again, that's just a methodological limitation for this project. And then I put down here a utilization wish list. acute care inpatient admissions are an easy utilization metric to calculate. It's fairly standard across all payers. But then you get into things like outpatient, and those of you who have even worked with Medicare fee-for-service data would understand that even just doing it for Medicare fee-for-service proved to be an impossible task, especially considering the time constraints we were working on. So we weren't able to complete all of these, but that is our wish list for this project. Next slide. We constructed a few chronic condition categories and calculated spending, both the allowed amount and out-of-pocket amount, for depression, diabetes, lung cancer, and opioid use disorder. Some of the considerations and conversations we had between the contributing partners were how many diagnostic slots were available in each of our claim system repositories, making sure that we were on the same page about that. And then just thinking through, were there providers or payers who were incentivized to include more codes rather than just a primary diagnosis in their claims, and did we need to take that into account? Next slide. We also considered and constructed some episodes. We calculated spending for these 4 inpatient categories: cesarean section, vaginal delivery, lower joint replacement, and stroke. They were demarcated using MSDRGs, and utilization was calculated as episodes per 1,000 beneficiaries. And some of the considerations that we had to take into account when thinking about episodes and putting them together in this way was considering the spectrum that payers, even within the ESI population, have when they pay for services, all the way from fee-for-service to total capitated payments. And so we came up with this like days prior and days after construct to capture all spending, inpatient, outpatient, and professional spending for patients utilizing these services. And then finally, we adjusted for age and gender to facilitate comparison across geographic regions and within payer group, but we did not do any age or gender adjustment between groups, meaning we didn't age and gender adjust between, say, our Medicare fee-for-service population or the MA population. And then specific for this project, and one of the considerations we needed to take into account when aggregating the data is that each institution has their own rules about the data and small cell sizes and what we are and aren't allowed to report. This is particular for the employer-sponsored insurance, that there was a sufficient mix of payers, that we weren't showing any individuals in cell sizes with less than 11. And then moving on to
2 minutes.
Dissemination strategy. If you can go to the next slide really quickly. For those of you that are good at multitasking, please navigate to the Healthcare Cost Institute website and you can actually scroll through. There's some great data that's available. Next 2 slides. And then the next one. We also provide detailed look at the data, including the opioid use disorder, spending on diabetes, stroke, and like I mentioned, the specific category for the Medicare and Medicaid dual eligibles. On the next slide, there's an example of what that looks like. This is looking at outpatient spending by county. There are 2 counties, and you can do comparisons and just dive into the data if you're a data nerd like I am. And yes, methodologies available, and so are FAQs.
All right. Okay, let me do the limitations and benefits real quick, and then we'll wrap it up here. I think the work that all these groups did was really, I think, kind of tremendous given the challenges. There were some things, of course, we couldn't do. As we mentioned a few times, since we couldn't get all the data in one place, we couldn't do any sort of pattern matching across the insurance databases, and that was unfortunate. But something that I think sometimes person matching within traditional APCDs is also a limitation. Daniel talked about the fact that we did some age sex adjustment for cost, but we couldn't do any complex risk adjustment. Usually you'd want to do something regression model based. We just didn't have that ability here. And then Daniel, I think, talked a lot about how ensuring data consistency really took up the bulk of our time. And also one limitation, I suppose, is that this took a number of people at a number of different places to get done. Even though we had, 100% of Medicare data, 100% of Medicaid data, and the biggest insurer in North Carolina all part of this, we still had about 40% of North Carolina residents that weren't part of the analysis. And that included a chunk of folks who would not be in a payer claims database anyway, who are uninsured, but there are other groups, other large group insurance companies, the military, we didn't have their insurance information, and then we could not include the individual market stuff right here. But in terms of benefits, look, there was no need to set up an entire team, an entire workforce, a data warehousing system and strategy in order to get all this data into one place. I'll jump to the last bullet here first, or second. It didn't require legislation. What it really did require was some eager organizations who were kind of ready to do this kind of work. And I would hope that if we wanted to do this kind of work again, that we could do research that was relatively quick and relatively less expensive than I think kind of the outlay that might be required in order to set up an APCD to do this work. So I appreciate your time. That's the end of this.
Thank you very much, Brad. And so before we break for the overall session in questions, I have one question for you. Most states face challenges in generating population-wide estimates of utilization and spending. Commercial data, for example, is often incomplete. I know North Carolina do not have an APCD, but for most APCD states, we have lost the self-insured eraser data due to Supreme Court decision, and also most recently in 2019, about summer, we have lost the federal employees data due to the Office of Personnel Management decision not to allow insurance companies to report to APCD states. So my question is to you, what is your recommendation for adjusting commercial claims to account for such incomplete data?
Daniel,
that's a great question. I mean, there's not a lot you can do except for work with each of the payers to get a better understanding of where the gaps may exist. A payer may not submit a place of service code, which may be required for you to be able to categorize where that claim belongs or what type of claim it is. So, I know with HCCI, we do a lot of work working with our national payers that we have in our database to make sure that we are receiving the data that we need to undertake this kind of work.
Yeah, and I would just say that the fact that we were able to get information on 60% of kind of North Carolina residents, I think that in itself is useful, and we acknowledge that there are holes, but I don't think too many things are necessarily going to go unnoticed in that even a good chunk of the population. So getting more data is really, I think, the goal. So even if you can't get it all, you're still going to learn plenty.
Okay. So I have one question from the audience, and this is for the folks for mental health parity. Has anyone studied what happens to mental health parity when the economy declines in a state across the country?
Yeah, that's a great question. I mean, I don't know of any study off the top of my head, but I think that further reinforces the need for capturing health plan coverage info, to see how it changes over time and how it might change over time of economic decline. And I don't know, it might be the question's kind of getting also at that, there are other factors outside of just like, the health plan design affecting mental health benefit coverage. But you know, that those are factors that would definitely need to be addressed or adjusted for in any kind of research at looking at health plan designs impacts on mental health usage.
Elizabeth, do you have anything to add?
Yeah, I mean, I think I agree. It's a really good question, and I hadn't thought too much about it. But yeah, I mean, I think cost is like ultimately probably, you know, the root of why plans sort of find these ways around parity and play with the language a little bit to create barriers. So I think that would be really interesting to see if the plans are designed differently during times where, you know, there's economic challenges and plans are trying to save more money. So yeah, thanks for that question.
Okay. So I have one question for the CDC folks. Although the completion data for disease registries is time consuming, the use of healthcare claims data may be delayed considerably by processing turnaround times. Could you please explain why this approach will lead to a more timely data access?
Gonza, do you want me to take that or?
Yes, I think Susan should do that.
Okay, Susan, thanks.
Sure. You know, as I noted early on in the presentation, most of our population-based registries that exist for things like cancer or reproductive outcomes and things like that have inherent delays in timeliness because of the reporting structure that exists. So for example, I can speak about Massachusetts because I was Associate Commissioner of Public Health there for many years up until my early retirement a few years ago. And so when we designed the cancer registry, we had to allow for a lag time in reporting. So every cancer diagnosis has to be reported within 6 months of that diagnosis. So that would basically mean that you'd never be any more current than 2 years out of date because of the 18 months that would pass. Having said that, I checked again this morning, and some of the data that are available in various states that we work with for statewide cancer data, one of the newest files was 2015. So when my colleagues at DIN tell me that the vast majority of claims are filed within a 90-day window, that's music to the ears of the environmental epidemiologist. Hope that answers it.
Okay, thank you very much. So this is a question for all the presenters. It's the same question. I'd like each of you to respond. So given that all the data you use today in your presentation today is pre-COVID-19, are you going to update your analysis to include the COVID-19 pandemic data? And if so, what types of study comes to mind that you may undertake? So, maybe start with Susan first. Anybody, so.
I will say that Gonza mentioned earlier, one of the things we were trying to look at was this pre and post period of time dealing with one particular environmental exposure concern, and that was pollution, some of the pollutants that were detected in the drinking water supply. Fortunately, we will have data from 2 years before intervention and several years after intervention. So I don't think that that should have too much of an impact on our analyses. Would you agree, Gonza?
Yes, I agree. Yes.
Okay. Thank you very much. So, so Charlie and Elizabeth, could you take a stab at that?
Yeah, I mean, it's slightly different, from our perspective, but as states and society both and CMS have responded to expanding telehealth coverage, right? So I think that we're going to see a lot more coverage for telehealth benefits for mental health care. And, the thing there, as states are thinking about updating the regulations about that, and issuers are updating their plan coverage, is that parity for, you know, what you're covering for medical surgical telehealth services needs to be, you know, at parity with the mental health side as well. So that's just something that folks are going to have to keep in mind as we're thinking about coverage in that area.
Thank you very much. And Daniel and Brad, take a stab real quick.
Yeah, I mean, I think our answer's easy, which is that we don't have any plans to update this analysis right now simply because it was a time-limited contract from the funding agencies that we had. But I think it would be very interesting to, keep this analysis as something we did every year to see how things change over time, regardless of COVID or not. So I wish we had the opportunity to, and we might yet.
Yeah, exactly. Agreed.
Well, thanks for everyone for your presentations. We have learned a lot today, and thanks to everyone who tuned in to listen, and all your questions you have put forth. Thanks again. Bye bye.
You.
Thank you, everyone.
Thank you.